Now, the discussion for today, I'm going to share my screen. Again, I'd like to thank Tom for his comments. I thank our support staff that keeps our webinar series going. And I also want to thank the audience for taking the time out of their evening to participate in our Patient Treatment Educational Empowerment webinar series. Our focus today will be on risk levels and treatment options for men newly diagnosed with prostate cancer. So Tom mentioned earlier that last month, we gave an overview of the treatment pathways on Finnpath.com. Now, this is a very novel tool that we're going to break down and peel back the onion on each one of its particular important layers. This evening, we'll be focusing on beginning your journey. This is where you'll find the newly diagnosed patient, and with emphasis on the risk levels and treatment options. But one thing I wanted to go back to is something that everyone needs to understand. Well, when you're diagnosed with prostate cancer, there's a lot of information up there. But one thing that Finn provides to you is a level of factual information that you can understand it has been vetted. And one of the things about Finn is Finn has pedigree. And our founder, Tom, and president, Tom Farrington, he's a 20-year prostate cancer survivor. And he experienced when he was diagnosed over close to 21 years ago, he experienced the normal challenges of identifying treatment pathways. And then once he identified the pathways and understood them, then he had to find what was the most appropriate treatment for himself. So when we start talking about Finnpath, Tom personally designed this novel tool to support not just African-American men with prostate cancer, but all men with prostate cancer as they travel along their personal journeys. So thank you, Tom. This is an excellent tool. Now, why is Finnpath.com needed? Why is because there's a need for current and reliable information. Finnpath incorporates newly approved and available treatment options. Also, it's easy to use. It consists of decision aids, which help guide you and your family's decisions with the doctor. But also, you don't have to download an app. It's in your hand, in your phone, it's in a tablet, or you can easily access it on a computer. Now, it also increases your knowledge. It improves your participation in the shared decision-making process with your doctors. Now, I'll talk about shared decision-making a little bit later. It increases your self-confidence, which improves your understanding of your treatment options. And when you roll the above four together, it makes you more productive, spend a more productive time with your doctor when you're evaluating your options or making informed decisions. So in the past, doctors would make a diagnosis, put together a treatment recommendation, and give it to the patient. And that's what the patient would do. Now, over time, research has demonstrated it was very important for the patient and the doctor to have a bidirectional communication, so the patient plays a role in their treatment options. Now, this works very well in some of the treatment areas that are not very complicated, but prostate cancer is very complicated, the treatment options that are available. So there is a need. And then one other point, there is a need for the patient to have a higher level of understanding of their disease and their treatment options. So now the doctor puts together a recommendation, but it's required, and also the patient requires a certain level of knowledge. Finnpath.com raises that level of knowledge and understanding of the treatment pathways. And what's important is it is as easy as typing into Finnpath.com into your URL on your phone, tablet, or computer. So if you type in Finnpath.com, it will take you to this homepage. Now, a lot of people have a tendency to look at the drop-down windows, but what we've done is basically, if you scroll down, you'll get to the treatment pathways window. Now, to keep it easy for the patient, we've basically broken it up into 5 different categories: initial prostate cancer diagnosis, PSA recurrence after surgery, cancer progression after radiation, advanced hormone sensitive cancer, castration resistant cancer. Today, this evening, we're going to focus on initial treatment diagnosis. So if we click on this, on the treatments button, it'll take us to this page. Now, this is the initial prostate cancer diagnosis page, and it's for patients initially diagnosed with prostate cancer before any treatment. But we don't want you to dive into looking at all the different pathways. What we want you to recognize is you have to understand your risk level. So if you click on the risk level bar, it will take you to this page. Now, this page helps you understand your risk level when you're newly diagnosed. The treatment options for men newly diagnosed with prostate cancer are based upon the risk levels, which is determined by your PSA, your biopsy results, your Gleason score and grade group, and your cancer stage. Now, all these factors together provide a broad foundation of the pyramid. So now you can determine your risk level. Now, once you have that information, what's next? Now you can go back and let's take a look at what each of these levels are. So we have a total, if you look in the corner, we have low, intermediate, high, regional, and metastatic. So if we look at our low risk, which is stage 1, I won't go into a lot of detail, but I wanted to identify some key points here. A PSA less than 10, a Gleason score of 6, a grade group of 1. So consistently between very low and low, you're going to have a PSA below 10 and a Gleason score of 6. So this gives you some simple information to think about when you're about to speak with when you're speaking with your clinician. Now from low risk, we can go to intermediate risk. Now this is stage 1 or stage 2. It's broken up into 2 categories, as you saw, similar to low risk. But again, I'm focusing at this time on the Gleason score, which is 7, on low risk was 6, and a PSA level between 10 and 20 versus a PSA level less than 10. Now, intermediate and unfavorable still focuses on a Gleason of 7, and your PSAs are between 10 and 20, but your grade group is increased to 3. And so now, the next one, if we move to high risk can be broken up into 2 categories also, and stage 3 and stage 4. You have high risk, and again, just to expedite my presentation, I'm just focusing on PSA of 20, a Gleason grade of 8 and 9, a grade group of 4 to 5, and the tumor is spread a little bit outside the prostate. Now, very high, you have a Gleason score of 9 to 10, a group of 5, and the tumor is spread to other nearby organs. And lastly, once the tumor is spread outside the prostate, it can be at a regional level, which is stage 4A, or it could be at a metastatic level, which is stage 4B. And again, it doesn't matter what your PSA is or your Gleason score is at this level. If you have lymph node involvement, which you will find in the stage 4A, or if it's distant metastasis, you'll be at 4B. No matter what, if you have these particular properties, you're in stage 4. So I go back, I have a hypothetical gentleman who comes in, he has a PSA, and if we look at some information, he had a PSA that we collected, was the question. He had a PSA of 12, a Gleason score of 7, a group of 3, and a stage of 2. So going back to the pyramid, we know that we have to focus on collecting this information. So in this case, the gentleman had a PSA of 12. So what we said earlier was it's not likely he's going to be a low-risk individual, because we know PSA is below 10, and a Gleason score, in this case, of 7 would put you in the low-risk category. But since we know his PSA was between 10 and 20, and his Gleason score was 7, it's highly likely he's at the intermediate stage group. So now with this hypothetical gentleman, or in this case, this is Mr. Johnson, and he will move back to the initial prostate cancer diagnosis page. Now that we understand the risk level, now we can go and get a little bit more information. Since we recognize he had a group 3, Gleason 7, group 3, and his PSA was between 10 and 20, we're classifying Mr. Johnson at the intermediate risk level. Once we have the intermediate risk, this particular category, then we can click on, there we go. We click on the arrows and it will take us to the intermediate risk unfavorable category. Now what you'll get here is these treatment options that are available for an intermediate risk unfavorable prostate cancer patient. Now, what's important that we want you to let you know is that when we created the tool, we don't want the patient to have to go out and search for additional information. So the Finnpath tool encompasses everything that you're going to need to understand what your treatment options are. So in this case, you have 2 categories of treatment options, depending upon whether or not your expectancy, your life expectancy, is less than 10 or more than 10. In this case, the difference between the two is the observational watchful waiting, which is in less than 10, or in this case, you have EBRT, deprivation therapy, brachytherapy, and surgery is the additional treatment option that's available. One thing I would like to highlight, which we've consistently said when we talk about the continuum of care, options that are available for prostate cancer patients. The clinical trial is a treatment option for the patient. So now I'll stop sharing, and it's time for us to introduce our panelists. Now, these panelists that'll be talking are survivors, warriors, who have a story to tell, and thank you for joining us. So we have Mr. Emerson Randy Hall, we have Barney Morris, and we have Donald Jones. Gentlemen, thank you again for participating in this webcast. And what I wanted to do is then thank you again. And I have a few questions that I want to start you out with. So in the case of Randy, so you're the first one on the block, first one on the panel. Where did you start on your prostate cancer journey? And what did you know? Did you know your PSA, your Gleason score, your biopsy, or your stage? And then the second component of this question is, what was your treatment of choice? You might have to get off of mute. There we go.
Yes. Well, as you know, I am a testicular cancer survivor of 45 years. And so my baseline back in 2014, was 2.8. And urologists have always said that my PSA would be a little higher. In October of 18, I came up with an 8 score. Later in November, it came back as a 5. I think that was after I didn't have any sex and I didn't ride a bike and some other things, and it came back as a 5. But then in February 19, it's a 7.1. So clearly something was going on more than just being a result of long-term cancer survival. I went to the urologist He immediately ordered an MRI. He was a new urologist, a change urologist. I moved to Florida. He immediately ordered an MRI, said, stop messing around with these PSAs, we're gonna see what's in there. That was not the normal clinical procedure, but this is what he said was best. It was what he called the new state of the art, MRI first. And that immediately showed that there was something in the prostate. And I had the biopsy. My Gleason score was a 7. And almost about 50% of the prostate. I was, you were describing earlier, I was a group 3 and a group 2. So group 3 was the highest sectional number, and group 2 as a whole. And treatment options, I had limitations on, that most people won't, because I had extensive radiation back in the 70s. I really didn't have I could have tried radiation, but if radiation didn't work, then I had no surgical option. So I decided that, actually, I think it was pretty much decided for me, because only a few of the physicians that I talked to would even consider a radiation process. Would be unlikely that surgery will work afterwards. So I had a prostatectomy. Now I will say that I had reluctancy. I had some fear, even though I had been through things, but I had decided, and I took almost 4 months to select the surgeon. I think one of the critical things that patients should understand, men should understand, that depending on where they fall in those 5 areas, you may have some time to find the best person with the best treatment option. And so I took the time, and I ended up, because of the access that I had, I ended up choosing out of the top 5 surgeons in the country, and had successful prostatectomy. My scores are 0 now. My major concern was UI, not ED.
Okay, so thank you. I want to take to stop for a second. So let's take a look at this, and I'm going to pull up. I'm going to share my screen, and then I'm going to bring up Finnpath. So, as I mentioned before, this is our Finnpath homepage. As I mentioned before, if you go to the drop-down windows, there's a lot of information. But I'm suggesting that everyone just scroll down to the treatment pathways section of the homepage, right? Then we're looking at initial diagnosis. And in this case, Randy just said that he had a PSA of 8.9, but his biopsy demonstrated that he had a 7. His Gleason was a 7, and he was a group 3. So just even though the PSA was below 10, we have to go with what the prostate biopsy was telling us, and that means that he was already in the intermediate risk level. So if we go to the intermediate risk level, and because Randy has demonstrated or suggested that he was a group 3, he had a Gleason 7, group 3. If we click on intermediate risk unfavorable, this arrow, it takes us to, again, this page that focuses on intermediate risk unfavorable. Since we already know that we're collecting information to determine your risk level, and he's provided us enough information to determine this risk level, now we can scroll down. So we know Randy's a young man. So he's going to be living up to his 90s. So in this case, these are the treatment options that were available to you at that time. In this case, they were suggesting, EBRT plus androgen deprivation, EBRT plus brachial therapy, all 3 of them. And then what you elected to take, which would be the radical prostatectomy and pelvic lymph node dissection. There's still always that opportunity of clinical trials. Now, this is where, if you take a look at this, this is where you fit. So if you're looking at what your options were at the time and whether or not you made the right decision, these are the tools, these are the pathways that were available to you at that time. And radical prostatectomy was one of those procedures. Now, if I stop sharing and I want to transition over to Barney, right?
Okay.
I'm gonna ask you the same question, right?
Okay.
And I'll repeat it. Where did you start your prostate cancer journey? And what did you know? Did you know your PSA, your Gleason score, your biopsy, your stage? And the second part of the question, what was your treatment of choice?
Okay. My journey is a little different, and a little different because of my age at the time I was diagnosed. I was diagnosed at 41 years old, which means I probably had it at the age of 40. Didn't have any symptoms. And fortunately, doing a routine physical examination with my employer, my PSA came back slightly elevated at 3.6. The conversation with my primary physician, she believed that that was a little high because of my age. And at the time, I wasn't aware I had any family history of prostate cancer. Went to a urologist, did the exam, the digital rectal exam. And ironically, in my case, it was a teaching clinic. So there was a student did the digital rectal exam and didn't feel anything. Primary urologist came in and asked me again, did he mind if he could check? And he did a check examination and felt a node. Fast forward, had the biopsy. Gleason score came back at 6, and stage was a stage 2 alpha, 2 atom, I think. And doing my research during that time period, there was extremely little information regarding Black males, 41 years old with prostate cancer. Most of the information related to men over 50 or so plus. So in making my decision, it came down to what was more than likely going to be the best course for me to provide longevity, being that I was so young. So in my research, it looked like that if you went radiation first, and if you were unfortunate enough to have a reoccurrence, then surgery was not, the surgery results wouldn't be as effective. So I went with the surgery, prostatectomy, had my prostate removed. So that was the reason I went that route. Thank God I did, because I did have a reoccurrence about a year and a half after, when my PSA started to bump up. It would quadruple every other month. And I went through what they call salvage radiation, external beam radiation. That was in 2006. And since then, I've basically been undetected. PSA has been undetected. So that was the reason that I chose the route that I did. But I tell you, there was very little information. Nothing like, Finnpath didn't even exist. And definitely there was little information when it comes to young men, 40 and under with prostate cancer.
So that's a very important point that you raise. So if you hadn't been tested, and so let's take this back. We're talking about 17 years. So one thing people in the audience need to recognize is that there is clearly it's clearly important to recognize early screening and how important it is, because you were diagnosed when you were 41, but you probably had it, even possibly earlier than 40. So if you hadn't have been checking that early, you would have never detected it. So what we can do now is, I'm going to share the screen again, and then we're going to walk through your information.
Okay.
So now I'm sharing it. I'm bringing up again, as I said before, when you I can get, yes, there we go. When you share before, when I shared before, we have the initial prostate cancer diagnosis. And this is, again, for patients initially diagnosed. So at the time, 17 years ago, you, from what we're hearing, is that you had a PSA between 3.6 and 4.2.
Correct.
And a Gleason of 6.
Correct.
So if that was the case, then you fell clearly within the very low risk or very low risk or low risk category. Now, we don't have a lot of any additional information, but it's just, we'll look at it this way and just go to, since you had recurrence, I'll stick with low risk. And from a low risk, again, and what I'd mentioned to the audience before, we also, your treatment options can be broken up into categories that reflect how long, what your life expectancy is. And if it's less than 10, then you would have fell into a category of observation or watchful waiting. But since clearly you were 41 when you were diagnosed, then we're talking about active surveillance, external beam radiation, brachytherapy, radical prostatectomy, and clinical trials. So in this case, your radical prostatectomy didn't work as well. And then you had to go for external beam radiation. So you could be comfortable that the choices that you went through for your treatment along your journey were the appropriate choices and for you. And this is, now I want to ask you a question. The question that I have is, Barney, how did you decide, how much time were you spending to kind of figure out what the appropriate option is? Because it sounded as if not only said, yes, the doctor said that we can do surgery, but how long did it take you to feel comfortable about what's the right pathway for you?
Realistically, about 2 weeks.
2 weeks?
You know, it wasn't long. You know, I wanted, you know, immediately after the diagnosis, you know, like a lot of men, I wanted it out. You know, I wanted the cancer out. And I was feeling like if this thing is in me, it could kill me, so let me get it out. Mm-hmm. But over those 2 week time period, you know, I got a second opinion. Went over to Mayo Clinic. This was in Tallahassee where I was diagnosed, mm-hmm. Southeastern Neurological. I went to Mayo Clinic. Didn't like what I heard from the radiation oncologist. I didn't like the treatment. You know, he actually gave me some incorrect information just from my basic research. I knew what he was telling me was not correct. So I from that point, I knew I really didn't want to go the radiation route. I was already leaning towards surgery. Then, you know, because of my age, I figured, you know, my position was to go ahead and get it out, remove the prostate completely. You know, deal with the side effects, if we will. I understood, I was aware of, you know, the nerve sparing surgery to minimize the ED, erectile dysfunction side effects. And I was in healthy enough shape. I didn't think I would have too much of a problem with urinary incontinence. And I didn't. Had some, but not a lot. So putting all those things into the pot, you know, in law enforcement, we call it TOC, totality of circumstances. I felt that surgery was the best option for me, and I would do the same thing again.
All right, that's great. So now we're going to bring in Don Jones. So Don, you want me to repeat the question again, or are you good? You're on mute, sir.
All right. No, I think I'm pretty clear on the questions. Okay. So my journey basically started in 2009. That's when I was living in Maryland, and my PSA began to elevate. So my primary doctor recommended that I go see a urologist. And you know, the PSA was kind of inconsistent. You know, it go to 3 point something, went up to 4, finally it got up to 5.0. And as I was seeing the urologist, they were like, well, you know, you're at a point now where we probably need to do a biopsy. So I got a biopsy done in 2009. I think there were 8 needles, and everything came back negative. There was no cancer found, no issues whatsoever. So we kind of went into the observation surveillance mode. And so from 2009 all the way until 2015, the PSA was kind of up and down. It'd go down to 2 point something, 3 point something. You know, it was just kind of bouncing back and forth. So in 2015, my wife and I relocated to Jacksonville, Florida. So at that time, I had another primary doctor. And once again, you know, he had my history, and they were again kind of keeping an eye on the PSA. And again, it was kind of bouncing up and down, but nothing severe. And finally, until about 2018, the PSA began to elevate up to 6.0. And so it got all the way up to 11.6, the PSA. And so at that particular point in time, I was, again, recommended to a urologist. And one of the things that he did, other than looking at the PSA numbers, because again, it was already up to 11.6, he went on and did an ultrasound and got some results from that. And then he had recommended that I go and get a MRI. And so I got that done as well. And basically the consensus was something was going on with the prostate, and that I needed to go ahead and get another biopsy in 2018. So I went on and got that. 2018, there were 8, again, needles. And out of the 8 needles, 3 of them came back positive with some type of cancer going on. So that was in August of 2018 with that biopsy. So, you know, I found out that urologists, basically, they recommend the treatment where they specialize. So he specialized in the removal of the prostate. And so that's, I mean, he basically just threw it out on the table. This is what we want to do. When do you want to do it? And I'm like, slow down. You know, first of all, let me process mentally what you've just told me, that I've got prostate cancer. Let me process that, and I'll get back to you. And so at that particular point in time, I started to do my own investigation, my own research, and I looked at pretty much all of the options, having the prostate removed, radiation, you know, therapy. But then down here in Jacksonville, Florida, you know, there is this University of Florida Proton Therapy Institution. So I heard about that, and I was like, proton therapy. Let me investigate that. And with this institution, you know, when you tell them that you're interested in that, they give you access to 2 books, 2 guys who actually went through proton beam therapy, and they shared all of their experience with that particular treatment. So I read all 2 books, you know, on the internet, doing all kinds of research. And, you know, because of basically no side effects, that was kind of the path that I was looking to go down. The problem was, again, my primary health provider, which is Blue Cross Blue Shield, back in August, they deemed that as experimental, you know, type of treatment, and they wasn't going to pay for it. So, of course, I had to fight with them from August of 2018 all the way until November, when they finally, and again, we had to go to a third party, and this third party finally told Blue Cross Blue Shield that proton beam therapy is covered under my insurance policy. So I selected proton beam therapy. I was entered and accepted into what they call a proton radiation compare study. is what they called it. And with this compare study, traditionally there are 40 treatments. I was approved for 20 treatments starting in January of 2019. I went through the 20 treatments. Prior to going through the treatment, again, my PSA was 11.6. After I completed the treatment, my PSA went down to 5.3. And as of March of this year, my PSA is 0.09. So it appears that the proton beam therapy did what it was supposed to do.
Okay. So what I'm going to do is take the information that you gave me, and to kind of recap, we had a PSA, you had a PSA of 11. You had a
11.6, right?
11.6. You had a Gleason of 7.
Correct.
Any other additional information about your group or?
Yeah, in my head, some, T1C is kind of ringing out, and I don't know what the T1C acronyms mean. I don't know if that means I was in group 1, but that just seems to ring out, but I'm not quite sure what group I was in.
So what we'll do is we will start with, we know it was your PSA was between 10 and 20, so that already put you into the intermediate risk group, and then the fact that your Gleason was 7, so we'll start at the intermediate risk group level. So if I share my screen again, so again, since we're focusing on initial prostate cancer diagnosis, we always go back to this page. And from there, we can, again, scroll down. Once you have all your additional information, once you've completed the pyramid and you know the 4 major factors that you need, or as much information as you had. In this case, we're able to we have the PSA and the Gleason. That's going to drop us down to intermediate favorable or intermediate unfavorable. And what we can do is, since we don't really have a lot of information, he did have a 3 out of 8, since less than 50% involvement. Let's just say, let's focus first on intermediate risk favorable. Again, Don, life expectancy, I think you're 63 or
63.
63 years old.
Right, I was 60 when I was diagnosed.
So if we, just to kind of a quick peek to let people see this is the actuarial, Social Security actuarial life table. And this is what they use to determine what the life expectancy for people in the United States. So in this case, Don was 60 or younger than 60 when he was, 61. No, what is it? Yeah. We're talking about 2 years.
Right.
Really? Yeah, 61 when you're diagnosed. Your life expectancy is about 20 years. And this is just from your actuarial table. So that gives us a focal point. Now, let's go back. And as I mentioned before with the other panelists, our treatment options are broken up into 2 categories. People that have a life expectancy, or men that have a life expectancy of less than 10 years, and then more than 10 years. And so this is the category, the section that you would fall under, Don. And in this case, there was the active surveillance, there was radiation, in this case, surgery, and then also clinical trials. So right then, the amount of time that you had to spend and the level of anxiety that you had to go in to kind of raise your level of knowledge, so you can even, and what was interesting, so you could even decide on, I wanted something a little bit more, something that was considered to be experimental, and from many people, and especially from the insurance companies, proton beam therapy. So now that we got, and I had an opportunity to hear everyone's journey and how it began and how you decided to make your treatment choice. I have another question. When you sat down and the doctor said you have prostate cancer, how did you make your treatment decision with your doctor? And were you satisfied with the discussions with your doctor? And I'll start with Donald.
As I basically said, you know, urologists recommend where they make their money. And in this case, no, I was not satisfied whatsoever with the discussion because he pretty much, you know, had tunnel vision. You know, I can remove your prostate. I can do my best to work around that bundle of nerves that live down there, but he couldn't give me any 100% assurances that if I were to go ahead and have my prostate removed, that he could be successful in getting around that bundle of nerves. So it was kind of, you know, iffy. And I'm sitting there saying, well, first of all, you know, you're talking about my life kind of in your hands, and I'm just not comfortable with you just leaning toward one way with no other treatment options. I was smart.
Did he even suggest other treatment options?
No, he did not. I mean, pretty much surgery was his only option. He did not talk about radiation. And when I basically talked about proton beam, it almost offended him. He wasn't very knowledgeable of that treatment option, and he was kind of disappointed that I was leaning that way versus not just having the prostate removed. So I was not satisfied with that doctor whatsoever.
Okay, let me jump to Randy. Randy, what are your question 2 again? How did you make your treatment decision with your doctor, and were you satisfied with the decision with your doctor?
My doctor, and this is just my opinion, makes most of his money related to the bladder. He doesn't do prostatectomy. And he knew that I was going to find or look for the best surgeon in the world. So, he recommended someone at Cleveland Clinic in Miami. And then I just went up the scale to Memorial Sloan Kettering and Mount Sinai and Hopkins, and interviewed these guys. And at some point they told my wife, if you threw a dart and you didn't hit one of us in the hand or the eye, you pretty much would get the same result. My wife is really, really up there in medicine, and she didn't like that kind of approach. So we finally picked a brother, Tawari, out of Mount Sinai, who, as I found out later on, almost everybody knows. Mm-hmm. Really, really great surgeon. I didn't have the kind of discussion that most people probably should have, depending on their level, because I had already experienced the radiation from the testicular cancer.
Yes.
So, and there weren't a lot of options. I looked at beam, just briefly. Most of the physicians that I talked to, which, they were high-level surgeons, although I talked to a few medical oncologists, they still felt that with the numbers that I had and the fact that I had had cancer, urologic cancer before, I should go the surgical route. And I was not against that because in my research, I found that the radiation pretty much had the same side effects just over a longer period of time.
Okay, all right.
So that's how I kind of got to that decision.
Okay, Barney, you're up. What's your thoughts?
Diagnosed. He was a urologist, and as the gentleman said, usually the urologist will lean toward surgery, and then the oncologist will lean toward radiation. Mine was a little different. I mean, he did say based on you as an individual, age and stage and so forth, surgery would probably be your best option. However, here are some other treatment options out there. And I suggest you go and do some research with the radiation, seed implants. He said that in 2004, basically there were, the seed implants, external beam radiation, and surgery was about the top three. He said, do some research and then come back to me in a week or after you talk to someone else, and then we'll go forward. So he was open. I mean, he really didn't push the surgery. He said, based on me and, my condition and the stages, surgery would have the best outcome. However, he did suggest I look at the other options and then make a decision with the information that I received.
Mm. So he asked you to go out and do your research. So there wasn't any information that the doc gave to you personally, or you had to go on the internet or get medical journals to understand what your treatment options were?
Well, he gave me some limited information, high level about the different type of radiation treatment and, the side effects for the radiation, side effects for the surgery. He gave me some brochures on each one of them, but that was it. And he recommended I actually talk to a radiation oncologist that have done the treatment to get a better understanding of the treatment for radiation. Now, he could talk extensively about the surgery and, what I could expect to receive as far as side effects, et cetera, et cetera. But he admitted, he said, I'm not a radiation oncologist, so here's the general information, but I recommend you go talk to a radiation oncologist, which is the right thing to do. Okay.
So I'm going to ask you another question.
Okay.
So if Finnpath was available at the time of your diagnosis, would your treatment decision have been different?
No. It would have been the same.
Mm-hmm. If Finnpath was available at the time of your diagnosis, would it have been helpful?
Absolutely. I mean, it was like, looking for a needle in a haystack to find information. And, what was really frustrating at the time, you get the information from radiation, you get the information from a urologist, then they get you in the room and say, okay, what do you want to do? You're sitting there as a novice. Yes, I can do some research. And I'm looking at it, well, you're the expert. Why don't you tell me what I need to do? And that was frustrating. So, by having an app such as Finnpath, would kind of walk you through all of the different options, the possible side effects, looking at all of the variables that come into play with this complicated disease, that would have been a tremendous help because it was frustrating. I mean, really, even after the surgery, I'm like, well, I wonder if I did the right thing. Luckily, based on the course of the disease, it turned out to be the right thing, but you don't know. So by having an app or program like Finnpath, now you have a definite path that you can follow. You have something you can sit down and put your questions together. So when you walk into a urologist or an oncologist, you are educated, and it's strictly from the Finnpath. And it's easy. You can do it at home. That you just can't beat it.
And I wanted to bring up something else too, just to make a little slight correction.
Okay.
There's a distinction between app that you got to download something onto your phone versus I'm just going to go to my phone. I'm going to go to my search engine or go to my tablet or even go to the doctor who sit at the doctor's office and he can pull it up on his computer. So there's no need to pull down sophisticated software to put in your information and collect data about you. This is free and it's easily accessible. Now, right. Don, I wanted to come to you with the same question. So if Finnpath was available at the time of your diagnosis, would your treatment decision have been different?
My decision probably would not have been different, but I'm one of those kind of people where, first of all, let me make the decision and let that decision include as much information as possible so that I can make an accurate decision. So if this app was available, I would have definitely used it, factored it in with all of my information gathering. But at the end of the day, my decision probably would have still been the same.
So for everybody here, if Finnpath will, if you think that from your feelings, Finnpath supports a patient in making the treatment decisions. So everybody's in agreement with that?
Yes.
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 Absolutely. Yes. And I wanted to reiterate, my physician actually did also sent me to a top radiologist. So even though he did not think that radiology was the way that I would go, he felt that I should have access to a professional and have a conversation about that. I think the issue with Finnpath is that if I had had that tool, it would have taken away, even at the level that I'm at where I have a lot of top information, I would have had less anxiety. Right. I would have known better and quicker what to focus on. You know, I probably would still have been forced in some ways to go down the decision road that I made, but I would know and have much more quicker and pointed conversations about my treatment options. And that's where I think the anxiety comes from, because you feel like you're struggling yourself sometimes to get to the answer that you know you need to stay alive.
So the tool itself is a novel tool, special tool, and really one of a kind that helps you along in your journey. And that's what I said when I will go back to that first earlier slide when I talked about Tom's, experience and how Finnpath is he weaved all of his knowledge and expertise about the prostate cancer patient's journey into this device. So that's all his, hurts, pains, redirections, just apprehensive, and the anxiety that you bring up. That's what comes out. That's being relieved. Now, what I wanted to do is go to my last question. Okay. And let's look forward. And I look forward, I look at Barney. And I wanted to acknowledge Barney is a 17-year survivor. Barney was detected early. So all those men out there who are in their 40s now recognize how important it is for a Black man to begin the discussion and begin screening. But again, at least the discussion. So I put Barney out there because Barney is your future. That's 17 years out. So I'll go to Randy. Where are you now on your journey? And what support do you need in making treatment choices now?
Well, hopefully, if I keep getting zeros, I'm cured, to say, hopefully. As you know, I wish I had a Finnpath for bladder cancer right now, but the way, as it relates to my prostate, probably the things that I would really like to have a Finnpath for are more like the side effects, understanding the impact of even simple things like exercise, the ED, the UI, so the medications, utilizing medications like Viagra on a long-term basis, even though it's a small percentage Viagra. There are things that I think that doctors tell me that are still not studied as well as they should be. And I think the other thing I would be is things related to maybe say a support group. Number one thing I find is that, like we're discussing this, when I had my prostate cancer, I found out later on how friends and family who had prostate cancer and never even spoke up, never shared it. Mm-hmm. The stigma is tough. And if there was a way to take us as patients, I love Barney's 17 years, and take us as patients and say,
I do too.
Each year, yes, keep tracking the patient. What is the patient dealing with? What are the long-term or, side effects or variables occur? And how do I help that patient understand that and make better decisions? Data is unbelievably a blessing. Correct data is unbelievably a blessing. And if we could get some of that, because as I say, this is not a death sentence. It does not have to be a death sentence. And as we get better and better at dealing with this, hopefully screening our people in the 30s or late 30s, getting those baselines early, we will find people will be detected early and they will be treated early and they will survive, like I had with my testicular cancer, 40, 50 years. So we have to have a tool that not just deals with the front end,
right,
very effectively with the back end.
Okay, Donald, same question. Where are you now on your journey, and what support do you need in making treatment choices?
As far as my journey is concerned, I think I'm in a pretty good place. I mean, this is my my second bout with cancer. Back in 1983, I had a cancerous tumor in the parotid gland area that required surgery, but again, because of early detection, there was no radiation and no chemotherapy necessary. Again, with this particular cancer, once again, early detection was key. The cancer did not metastasize, it stayed within the prostate. And as a result, it appears that the treatment option that I chose was effective. So I think I'm in a pretty good place mentally and physically. The other key is I've got a tremendous support system with my wife. We've been married almost 31 years. When I went through this treatment with prostate cancer, every appointment, every whatever I had to go through, she was right there by my side. So it is so important to have a supporting spouse. And again, I'm going to concur with the other gentleman. We need to be having these discussions regularly and frequently with as many men as possible. I know right now, and I've got a personal journey. I'm on my way back to Maryland in a few days. And one of the things I'm going to do while I'm up there, again, I know some brothers. I want to share my story with them and get people talking about it, that it's not something that you ought to be embarrassed about, ashamed about. It happens. But again, if things are not normal, if your PSAs have some irregularity to them, raise that flag. As far as treatment options are concerned, if people are telling you no, you can't have that treatment option, you got to make up your mind. This is the one I want, and I'm going to go after it and until I get it. So the final thing I want to say about this is the fact with organizations like FAM, I learned about you guys maybe a couple of years ago when when Tom came down to Jacksonville, Florida, and I was able to see the play. And right then and there, I made a decision. If I can be somewhere involved in Finn, I want to be, because I want to get the message out. So I think organizations like this is good.
Thank you very much. Appreciate it. And you touch upon some key points, especially about not effectively communicating. People are holding it in and not really telling everybody about the fact that they have prostate cancer, and holding the anxiety in them instead of taking the time to sharing it with us. So again, as you go to up north from Florida, since all of you guys are in Florida, I take it, when you make that trip up to Florida, when you make that trip up to Maryland, okay, it'll be warmer. But make sure you give them Finn information. You can give us. You have the telephone number. You can give them the telephone number. That's what we want you to do. So everybody needs to know about Prostate Health Education Network, Finn. Now, Barney, you're the last person up.
I'm the last person.
And then you know at Georgia Stadium in the background.
Okay, let me put up Tampa Bay. Hold on a minute.
Yeah, okay.
In my journey right now, I'm in a survival mode. And right now, what I I feel my challenge is to share information. And that's where I see one of the most important things this Finnpath can do is to share information. I really think the time to review the Finnpath is before you get diagnosed with prostate cancer. I mean, these guys can testify. It's a shock when you get that diagnosis. Just think if you have had the opportunity to review Finnpath before, especially those that have a family history of members in their family with prostate cancer. By all means, take a look at the Finnpath app, and now if you're unfortunate enough to join this tremendous club, at least you have some information on what you're going to expect. Don't wait until you get diagnosed. So that's what I see my journey is. You know, I speak a lot. I'm out and about, and I'm gonna use this tool as put it in my tool bag as to share with other young men, especially young men, because you know I can testify to the fact it can hit you early in life, and that's where I am. Get the information out. Learn as much as you can. And like I said, I'm gonna use the Finnpath as another one of my tools. And again, don't wait until you get diagnosed with cancer, prostate cancer. It's not a death sentence, but the more information you have can prepare you to make the best treatment plan. And I want to say something. It's critical to be part of your treatment team. I received a misdiagnosis where my cancer metastasized to my skeletal system. But because I had done some education, some research, I knew that was not an accurate diagnosis. I had learned how to read an MRI, I put my MRIs up charts, and I knew, I said, this is not right. So you have to be a part of your treatment team. And so the more information you have in your tool bag, and I think Finnpath is definitely one of those tools that should be at the top, because it can save your life. Because had I gone with that diagnosis, I wouldn't have been here, because they'd given me a 5 to 6 year life expectancy. I was 46 years old then. I'm 58 now.
Mm-hmm. All right. Thank you, gentlemen. And what I'm going to do right now, thank you for taking the time and just telling your story and telling your journey. But I want to take this time to hand it back off to Tom. I know he has some things we have some additional questions, and let him close us out. Thank you, gentlemen.
Thank you, Keith.
Thank you, Keith. And I want to thank our panelists for their great stories and willingness to share, because it's important for men to share their stories to help others. And, that's the way I got started with Finn. I was in treatment, and I shared my story, and other men began to share theirs. And I wrote a book about our stories, and that's what led to the founding of Finn. So you can do great things by telling people your experiences and listening to theirs. And that's what we try to do, and that's what we were able to facilitate here today. And again, I thank you guys for doing a great job in helping us meet that goal. One of the things I do want to point out that Keith mentioned, that I am a 21-year survivor, and putting Finnpath together was based somewhat on my experience, but also Finnpath is based upon the National Comprehensive Cancer Network treatment guidelines. And these are guidelines that are used by doctors. When they are making their decisions, they use these guidelines. The insurance companies use these guidelines to determine what treatments that they will cover, what procedures they will cover. I sat on that treatment guideline panel with some of the best doctors in the country. I am a patient advocate there. And I can let you know, we spent a lot of time going through different treatments, different scenarios to come up with these guidelines and options that you see for the different cases of treatment. So there's a lot of work that goes into putting that together. These doctors take it very serious. As a patient advocate, I certainly throw my voice in. And so what you see there is based on Finnpath is based upon those guidelines. And my experience certainly factored into those guidelines. So I think at this point, we want to do some Q&A. And so I've seen a couple of good questions. There's one, I think, from that says, my Gleason score initially was 3+3 without change for a year. It then went to 3+4. How important is the way the Gleason score is shown? 3+3, 3+4, 4 equal 3. What happens with the Gleason score is that it's based upon the tumor tissue. The tumor tissue is tested, and then they'll come up with a score. And a lot of times, that score is based upon the tissue that's taken from the tumor. So you may take tissue from a different part of the tumor that may actually read differently than the initial Gleason score. So in many cases, Gleason scores are upgraded after, let's say, surgery, because you have surgery, you can go back and run the Gleason score on that tissue. So the 3+3 is a 6 that puts you in a low risk category. 3+4 puts you in a intermediate category, favorable. A 4+3, which means there's more 4 than 3, puts you in the intermediate unfavorable category. So so I hope we've answered that question. Another question I have: prostate cancer, when my recent PSA is 4.6, I had biopsy was positive, the MRI was positive, the bone scan is negative, and my Gleason score is 9. I am 62 with a family history. I am scheduled for radical prostatectomy in May 2021 at Brigham and Women's Hospital. I do have glaucoma too. I thank God for the great physician. He gave the physician name, and I'm not going to say it here, but I do know the physician. The physician is, I agree, is a great physician. He's spoken with us. He's been on our program. So I think you have a good physician. There was no question there as I read it, but I will say to you, I think you chose a good physician. Okay, good. So another question that we had was the difference between observation of watchful waiting and active surveillance. And if you go back and look at the treatment options that Keith presented, in some cases, if the life expectancy was 10 or less, you would see observation, watchful waiting. If it was 10 or more, you would see active surveillance. Now, the difference between the two is that with observation, you literally, you watch the progression of the cancer, and you take action if action is needed. And with active surveillance, what you do is you continue to do biopsies and monitoring on every 6 months or every year, but usually on an every 6 month basis to see whether you need to have immediate treatment. So with observation, the thought is that there will not be treatment because the life expectancy is less than 10 years, and that many men over that 10-year period will not progress to the point that they would need treatment. So you just watch it, and if you do see a major change, you may want to have treatment. Active surveillance, you want to make certain on a continuing basis that you do your biopsies to see where you need to come in with treatment. And a lot of men will, well, I shouldn't say a lot of men, but men do opt after active surveillance and continuing biopsies to have immediate treatment. Actually, for the data that I've seen, is a more African-American men go from active surveillance to active treatment than other men. So I hope I've answered that question. Okay, do we have any additional questions there? Another comment here, sometimes those blind biopsies will miss all the cancers. One of my biopsies did as well. And that is true. There is, you can have the biopsies, the needle biopsies, and that's the reason MRI biopsies, MRI now is so important because you can detect cancers that you may miss with the biopsies. In fact, we had a doctor, I think it was back in 2014, speak at our summit in DC that talked about the anterior section of the prostate, and more Black men have cancer there. And it was one of the reasons that cancer is upgraded after prostatectomy, because they could not reach that area with the biopsy initially. And anybody wants anyone on the panel have anything to add to that?
Well, as I said, I had 8 needles in my biopsy, and as you said, 3 of them came back positive, and I'm looking here where it said the right inferior base, I had a 3.3, the right interior apex was a 3.3, and the left inferior apex was a 3.4. So I had a biopsy done in 2009 that did not detect cancer, but then the one that I had in 2018, the urologist said he went up further in the prostate, and as a result of that, the cancer was found. Yes, absolutely.
And using the ultrasonic, they use needles with the ultrasound, and it's really kind of hit miss. When I had my biopsy, I had 12 cores, and I think 9 of those cores were positive, and the other cores showed a high pin value. So it looked like on my prostate, wherever they hit it, it was positive.
Yeah, that's how mine was. I think it's important now. Back then, I had an option is to have the MRI,
right? Absolutely.
In conjunction with the needle biopsy.
Right. We have some people with the hands raised. Okay. Can the biopsy procedure reach the anterior portion of the prostate using transperineal needles? I guess the biopsy, and this is what we were just discussing. It is difficult, and that again is the reason that the MRI is so important now. Do I have another? I see another hand, but I don't see a question. Okay. All right. I hope I'm not missing anything. It says, okay, how soon after EBRT should you retake your PSA? Okay. Actually, I guess Don and I are the ones who had radiation, and Randy and Barney had surgery. Usually, I think after I had radiation, it was about 6 months when I had my PSA, and the difference between a PSA meaning for radiation and for surgery. For surgery, the PSA should be non-detectable immediately after removal of the prostate. With the radiation, your PSA will go down slowly. And so there will be a PSA value that will remain. In fact, I think it was more than a year before my PSA reached its nadir point. And so that is a scary time, Donald. I don't know your experience with that, watching that PSA go down slowly.
Actually, I finished treatment February. I think it was right at the end of February of 2019, and my PSA went from 11.6 before treatment to 5.3. So it went down, but it didn't go down to the number I wanted to. But now, as of March of 2021, it's 0.09. So
0.09.
Yeah.
That's a good number.
Yes.
That's good number. We want to keep it there.
Correct. Okay.
I I see more questions. Let's see. I have a comment, and I want to agree. All the panelists were great. Let me echo that. One note to share, although proton beam therapy is a newer treatment option, it was one of the ones I was considering initially based on another friend in Finn that chose that option pathway. The only drawback was I had a hip replacement, which obstructs the beam. So that's interesting. So
Yes.
yeah, that's interesting.
Yeah, because again, that beam goes right on the hip on each side. And actually, after I went through about 5 or 6 treatments, I developed these black spots on my hip on both sides because of the beam. So yes, that is true.
Another question, is there an upper age limit on not doing PSA age 70 plus? Now, for those men who have been treated, there is no age limit. You want to get your PSA. I'm 21 years out, and you know, I get a PSA still every 6 months. I don't know about you, Don, but I want to see, make sure everything's in place. So for men who've been treated, you want to get your PSA. In fact, the PSA test was originally developed to monitor men who had been treated. The PSA level for men who have been treated for prostate cancer. It's a biomarker which could tell if you've had a recurrence of the disease. However, now if you're asking the question relative to early detection, whether there's an upper limit, you know, the U.S. Preventive Services Task Force recommends that you don't need to do PSA testing after age 7. What Finn recommends is that should be based on your life expectancy and your health. So I've seen some 88-year-old men that are in very good health that I would recommend that they get a PSA test. So I think it's a function of that. Again, prostate cancer grows slowly. So the key thing is that if you're at an age where let's say less than 10 years to live, let's say 5, again, based upon the tables that Keith pointed out, then even if you're diagnosed with prostate cancer, chances are you don't want to risk the side effects of treatment. However, if you're 80 years old and you think you're going to live to be 90, 95, and some men do, then a PSA test is important to you. Do you have life expectancy tables for Black men who are 60 or older? That's a good question. I'm not sure that they exist based upon risk, but you know, we'll check that out. We really will check that out. That's a good question. Randy, did you want to comment on that? You're on mute.
Okay, I think that Finnpath, tool that it is, could be very helpful in trying to understand where life expectancy comes into a person's decision. When my physicians were talking to me about life expectancy, I didn't hear any of that. Mm-hmm. It was 100% for me, however long I'm going to live. So you have to be really careful because, and I think some of this is also about diversity, but people make certain decisions about how long you're going to live, and they're not always looking at that number on those charts.
Right.
You know, and, you know, my father-in-law had to be 100, and he was getting PSAs in his late 90s. Right. And he was in very good health until the last couple of years. So I always say to people, if you feel that you are going to continue to live, really think hard when they start talking about making treatment decisions based on how long they think you're going to live.
That is a great point, Brandon. That's a very good point. You know, you have to factor in the genetics, your family. What do you see in your family? And also your personal health. How good is your health? If your health is very good and you're at 75 or 80, as I said, you have a chance to continue to rock on. You want to take as many tests as you can. I think those are all the questions that I see that we have. So I do want to say to the audience, we really appreciate your joining us. There is a poll, a survey that you will see once we finish this. It will you will see it on your screen. We would appreciate your filling that out and completing that. This program will also be recorded. It is being recorded. It will be posted on Finn TV, and it will also be posted on Finnpath. So on Finnpath, we want to share patients' experience. So these webinars will be hosted there. So all of you would be able to go to Finnpath and in just a few days to re-look at this program if you like. And so I do want to take time again to thank Barney. Thank you for being with us, Barney. Randy,
my pleasure.
Thank you so much for being with us today and this evening. And Don, it's good to see you again. And you know, I was talking with the people in Jacksonville. We're still doing some things down there with Meriwether. You may know AJ, and so we're still active there. So I really appreciate you being with us tonight as well.
My pleasure.
And with that, and with all of our audience, and don't let me forget Dr. Crawford. Dr. Crawford did a great job putting this program together and moderating it. So Dr. Crawford, thank you for a good job this evening.
Well, thank you very much. And then I want to remind everybody, if we didn't get to your question, send us an email. If you weren't comfortable about putting it in a chat box, just call us up or send us an email and we will respond. Okay? So we just want everybody to know that.
All right.
Thank you, Tom.
Thank you so much. Thank everybody. And again, thank our sponsors. I don't want to forget our sponsors. Thank you, sponsors. So we will see you next month with another program. Good night.
Yeah.